All right. Hi, guys. Welcome to the digestive system lecture. So, first things first, the organs of the digestive system are broken down into two different groups. First is the alimentary canal, aka the GI tract or the gastrointestinal tract. All three of these are the same thing. We typically just call this the GI tract. But know all of these and know the parts associated because you will see this on the test or the quiz. So the GI tract encompasses or includes the mouth, the pharynx, esophagus, stomach, small intestine, and large intestine. So it's all the tubing from one end of the body to the other end of the body, moving food in and through. And then the second grouping isn't necessarily one that food goes through directly. So we call these the accessory digestive organs. And they provide the enzymes or secretions or liquids that help the entire digestive process. So these organs include the teeth, the tongue, the gallbladder, and the glands that we call the salivary glands, the liver, the pancreas, all of those. So know which organs are in which grouping. So know the GI tract, the alimentary canal, versus what's in the accessory digestive organ, so that if it does pop up on a test or quiz, you know what to do. These are the digestive structures that we will get into in this lecture. So we've got the mouth, the tongue, and the esophagus, aka the food tube. We have the salivary glands up here, the parotid, the sublingual, the submandibular, the pharynx. Remember, there are three parts to the pharynx, but over here you can only see the laryngopharynx. Anyway, all you'll need to know is where the pharynx is located here. Let's see. We have the stomach, the pancreas, the spleen tucked into the left side over here. So an easy way to remember where the spleen is, imagine that you are the driver. You're driving a car and someone T-bones you at the driver's side. So the spleen is going to be on that side. So that's the left side, right? We're talking, driver's side here, not driver's side in Britain, right? So we're on the left side. We get T-boned. The spleen's on the left. Well, there are ribs that are shielding the spleen. Should those ribs break, if you get T-boned while driving a car, they can actually lacerate the spleen and cause you to bleed to death. So with that story, you should remember that the spleen's on the left side. And we talked about spleen a little bit in immunity. So you know about, issues there. That can happen with bleeding out, etc. The liver is going to be the largest organ here. Ginormous. Gallbladder is this little pear shape that's tucked underneath. It's green. We have the small intestine, which contains all the skinny, wormy looking loops on the inside. And we have the large intestine that pretty much frames the small intestine on the outside. So most of these things, you've already heard of. You kind of have an idea of where it is. The large intestine is made up of three pretty basic parts. We have the ascending colon, so it's just as it sounds, going up. We have the transverse colon going across. We have the descending colon going down. And then we also have the sigmoid colon, which just means S-shaped. Sigmoid literally just means S-shaped. So that's down here at the bottom where it starts turning into an S. We have the rectum. And then the anus at the bottom. But between the small and large intestine, there's this little junction right here. And that is where the appendix is located. So you can remember it. It looks like a little pigtail junction between where the small intestine turns into the large intestine. It doesn't look like much, the appendix doesn't, but you do not want that bad boy getting inflamed. So now we have layers. We have parietal and visceral yet again. So same rules apply. We've seen these two pop up throughout this entire semester, right? Parietal lines the cavity, visceral lines the outside of the organs. So these two are called the peritoneum. We discussed the peritoneum a little bit in a previous chapter, but the parietal peritoneum lines the abdominal wall and the visceral peritoneum lines the outside of the organs. Between those two layers is a space, or a cavity, if you will, that we call the peritoneal cavity, and it contains fluid that lubricates the organs and prevents them from sticking together. So if that cavity becomes inflamed, it's called peritonitis, and we don't want that to happen, right? So remember, visceral organs, know the difference: parietal, abdominal. So visceral, outside of the organs; parietal, abdominal, as it pertains to the peritoneum. Remember the kidney lecture? So we mentioned retroperitoneal organs, and we use kidneys as examples. So now is when we talk more about these. So retroperitoneal organs are outside of the peritoneum. Part of the intestine is retroperitoneal. We're not really going to get into that a whole lot. And the kidneys are retroperitoneal. Everything else is intraperitoneal. We just call them peritoneal organs. And that's everything that's on the inside. So literally everything that we just looked at in slide 2 is a peritoneal organ. So when it comes to digestion, we're going to start at the mouth and work our way down the digestive system. So the gingiva is the technical name for gums. You've probably heard this term in the dentist's office. If you haven't, and then pay attention next time you go to the dentist, because they do say this a lot. There are a lot of posters about gingiva and about the importance of keeping your gums healthy so you don't get gingivitis, which we'll talk about. But gingiva, the gums, they should be pink. If they are a pale color, then you're probably a little bit anemic. And if they're red or bright red, they're probably infected, and that's what we call gingivitis. We have this little tag right here that holds your lip to your gums. The one on top is called the superior labial frenulum, and at the bottom it's called the inferior labial frenulum. Labial just means lip, whether we're talking about the mouth or female reproductive structures. And a frenulum is just a fancy word for something that ties something down. So this is something that ties the lip to the gum. We also have a lingual frenulum. So anytime you see the word lingual, it refers to the tongue. So use the tongue to talk, to use your language. So lingual frenulum ties the tongue to the gum, right? This is the only one that can really cause a problem, the lingual frenulum. So if this frenulum extends to the tip of the tongue, someone would say that they are tongue-tied. If a baby is born with this extension, then that baby, if the baby can work around it, then it's not a problem, but some babies can't. So what this means is they can't stick their tongue out to latch onto a bottle or a nipple to breastfeed or bottle feed, and that can cause them to starve to death because they can't stick their tongue out past their teeth and latch on to suck. So back in the day, this was a really big problem. Today, to fix this, all doctors do is clip the frenulum and make it so it's not so tight, and so the tongue is more mobile. It's a very simple procedure nowadays. Oh, and I forgot to say this while we're talking about the gum, the lip, the frenulum, the vestibule right here. That's just that space down here, the little pockets, open pockets between the gum and the lip. Anyways, very simple procedure to clip that frenulum back. Let's move on. Hard palate, soft palate. We talked about those. So palate just means plate. Really easy to differentiate between your hard palate and your soft palate. Just move your tongue. Start at your teeth on the roof of your mouth. Work backwards. Once you pass that hard plate, you'll feel that soft plate. That's your soft palate. And if you keep working your roof backwards, you'd hit the uvula. So the uvula is the dangly thing in the back of your throat. It hangs down from the soft palate. If the soft palate, it can elevate and it can drop depending on what you're doing. So if you're swallowing, it elevates and closes off the nasopharynx so food doesn't go up your nose. When you talk, it changes shape and it helps you control the sound with how you make words and syllables. And then what else do we have here? Palatine tonsil. So remember tonsillitis? We talked about that in a previous lecture. Palatine tonsils, tonsil stones, little crypts where bacteria can hide. And that's about it for mouth structures. So hard palate, soft palate, just discuss that. But I did forget to mention that the hard palate is lightly ridged or corrugated, and that actually helps to create friction against the tongue to hold your food in place. It also creates a solid place to put your tongue while you're talking. So you're going to be thinking about this next time you talk, probably. Maybe not. I do. I'm thinking about it now, about how the tongue moves inside your mouth when you're talking. It's interesting when you start thinking about talking. Anyway, let's continue. The tongue. So, first things first, all these bumps, all these papilla on the tongue, they are not taste buds. You cannot visually see taste buds with your actual eyeball. You cannot see it with the naked eye. Now that that's out of the way, let's talk about these papilla. So each papilla have a different function. And the taste buds are actually on the sides of the papilla. And they're very, very microscopic. Like I said, you cannot see them with your naked eye. So filiform papilla, it looks smooth pink, but if you really look closely at your actual tongue, you'll see that the smooth part that you think is smooth is not actually smooth. It just is really, really tightly packed with these little extensions, these little filiform papilla. The filiforms, an easy way to remember that it's what looks like it's going to be the smooth tongue. It's the fill-in of the tongue. So filiform, fill in the tongue. Fungiform papilla. So fungiform, fungi, fungus. You can remember this as the little papilla that stick out like mushrooms stick out. But these are all across your tongue. Fungiform papilla provide pretty decent grip on your food. So filiform, fill in the tongue. Fungiform, stick out like little mushrooms, like little fungi. The circumvallate papilla. Circumvallate, it has a V in it. That is the V-shaped papilla on the back of your tongue. So that's a good way to remember that. And then on the side, we have foliate papillae. Foliate, think foliage, think leaves. If you squint, look sideways, these could maybe look like halves of leaves. That's a good way to remember foliate papillae. So foliate, foliage on the side, circumvallate, V-shaped, fungiform like little mushrooms, and then filiform, fill everything in. And then we've got the lingual tonsil at the base of the tongue. And you're not probably going to be able to see that. I would be very shocked if you can. If you have strep or tonsillitis and your throat is sore or you're feeling like it's closing up, it could be due to an inflamed lingual tonsil. Whoops, got a little ahead of myself there. All right, glands of the face. So the parotid gland is the most encountered specifically during mumps. So that's the gland right here in front of your ears. So mumps is a viral infection of the parotid glands. Most of us get vaccinated against this. We'll never have this. Know this, okay? Parotid gland mumps. Anyways, mumps cause the parotid gland to swell so bad, it causes the person to look like an actual chipmunk. Okay, so that's how you can remember the location of the parotid gland. Parotid gland, mumps, chipmunk. And then there's a duct to that. Let's see. That runs from the parotid gland all the way to your teeth. And you have the sublingual gland. So lingual, remember tongue, was sub mean beneath. So you have the sublingual gland underneath your tongue. This is one that causes you to accidentally squirt saliva out of your mouth while talking. Everybody's done it. If you say you haven't, you're not telling the truth, because everybody has accidentally done this at this point of life. But yeah, if your sublingual gland gets too full, you will squirt saliva from under your tongue unintentionally. And we have the submandibular gland. So this is underneath your mandible or your jaw. This one you cannot feel unless it is swollen. What can cause it to swell? Different things like allergies or viruses. So remember immune system. Remember what, immune functions, glands do, etc., etc. Allergies or viruses can cause this to swell. So if your doctor ever feels under your chin and says your glands are swollen, that's what he's looking for, because otherwise it doesn't palpate and you can't feel it unless it's swollen. And if it is, if you do have severe allergies or some kind of infection, it can actually feel like a golf ball underneath your chin. So feel that. Now's a good time. Now's allergy season, right? If we're in the fall, flu season. So feel under there. In Kentucky, spring or fall, doesn't really matter. Allergies, infections are all around us. So if you ever do feel under the weather, just feel those different glands and try to self-diagnose. I mean, go to the doctor, but it's cool to kind of, be able to be like, oh, hey, I learned this in anatomy class. Crazy. Anyways, moving on. So parasympathetic nerves stimulate salivation. Write that down. Know that it will show up. Parasympathetic nerves stimulate salivation. So saliva cleans the mouth, it moistens the food, the tongue helps form a bolus, B-O-L-U-S. So a bolus is just a mushy ball of food. Saliva helps move that. Saliva also has enzymes that help start to chemically break down your food. Now there's not a solid flow of saliva all the time, or you would be drooling all the time, right? So you want saliva when you need it. Salivatory nuclei in the brain cell stem, we can call these nerve cell bodies. So salivatory nerve cell send impulses along the parasympathetic fibers. So rest and digest, and that's what turns saliva on. Parasympathetic nerves turn saliva on. Sympathetic nerves turn your saliva off. Sympathetic is the fight or flight response. So if you are super stressed out, your nervousness is at an all-time high, you could have dry mouth or cotton mouth, because your fight or flight response has turned the saliva production off, right? So remember, parasympathetic turns saliva on, sympathetic turns saliva off. You always want to be on off, you don't want to be drooling all day. And you don't want to have severe dry mouth. Cotton mouth's never fun. All right, so mouth, tongue, glands, saliva. Let's move on to teeth. So we got 2 sets. Got primary and permanent. Primary teeth, aka milk teeth, aka baby teeth, aka deciduous teeth. Now, most people don't know deciduous teeth. Think about it like deciduous tree leaves, they fall off. Deciduous teeth fall out. So primary, deciduous, milk teeth, baby teeth, all these are referring to the same teeth. And these happen between 6 to 12 years old. You have 20 of these teeth, and you the teeth fall out around 6 to 12 years old. They start falling out between 6 to 12 years old, and you have 20 of them. You start getting them around 6 months old, plus or minus a couple months. Some babies get them a lot sooner. By 2-ish years of age, you probably have all the primary teeth that you're going to have. Once those start falling out, they get replaced by permanent teeth. And you end up with 32 total by 21 years of age. Although your third set of molars, that we call the wisdom teeth, sometimes don't come all the way through. By this point, all of you guys should know about wisdom teeth. I'm sure most of you had to get them surgically removed. I did, especially if you had braces that moved your teeth before your wisdom teeth started coming in, right? So if you had braces, it moved your teeth, your wisdom teeth haven't started coming in yet. Now, years later, your wisdom teeth start coming in, there's not space, right? This is why it's important to go to the doctor, get x-rays. Wisdom teeth can move the rest of your teeth that you just spent years correcting with braces. So you want to get those surgically removed. I don't think I am teaching anybody anything with that information. Pretty sure most of us are very, very well aware of the joys of having wisdom teeth. This is a panorama x-ray. Think panoramic picture on your phone. Starts at one side of your face, works all the way around, stops at the other side of your face. You can see, I made them deciduous teeth here, but your primary teeth, your baby teeth, you can see how the permanent teeth that are coming in are pushing the deciduous teeth out. You can also see the molars moving through the skin here, right? And then you can see the little third sets of molars, the wisdom teeth right here, trying to move through the skin. Now, this person is fortunate that the wisdom teeth are pointing up. My wisdom teeth were impacted. They were pointing toward the middle, and I did wear braces, so my wisdom teeth were only going to cause problems if my dentist allowed them to grow. So they would have moved my teeth that my braces had just corrected. So once those bad boys appeared, they were surgically removed so that they would not cause any problems. Let's talk about a little bit more specifically about teeth. So we've got incisors. They are chisel shaped. They're used for cutting. We have canines, so think fangs, like dogs have fangs. They are for puncturing, tearing. Molars are used for crushing and grinding. So our premolars are kind of in between. We call them bicuspids. They have 2 cusps or 2 bumps. So you don't see premolars really in primary teeth. That's moving on to the permanent teeth. But anyways, premolars, bicuspids, they got 2 cusps. Feel your premolars, you can feel that they kind of feel different from the rest of your molars, almost like a in between canines and molars, and that's exactly what they are. And then you have 3 molars in the back, 1, 2, 3 potentially if they come in normally, or you won't have them at all because you got them removed surgically or you got them pulled. Yeah, those are our teeth. The way we count them with primary is 2 incisors, 1 canine, and 2 molars. You got a central and a lateral incisor here, one canine, and a first and a second molar here. And then same on the opposite side, right? Permanent teeth, same thing. So 2I, 1C, 2PM, 3M. So we've got incisors, 2 of them, central lateral. We've got 1 canine. We've got first premolar, second premolar. So 1, 2 premolars, and then 3 molars, 1, 2, 3 molars. But like I said, the third molar, the wisdom tooth, is kind of the toss-up. So that's what 2I, 1C, 2M refers to. I is incisor, C is canine, M is molar, PM is premolar. And that's how dentists count teeth, or dental hygienists. So if you see this next time you go to the dentist, you kind of know what they're looking at. Parts of the tooth. So the enamel is the outside. It is the hardest substance in the entire body. Dentin, which is right below the enamel, is a lot softer. The pulp cavity is the inside. It contains the blood vessels, the nerves, and this is what hurts if you begin forming a cavity, aka dental carie. It's weird to call it a cavity when we're talking about the inside of the tooth being called a pulp cavity, but a carie is the actual word for, the cavity that you have to have filled because it shouldn't be there in your tooth. So anyways, the pulp cavity, that's kind of where that whole thing happens. The blood vessels and nerves run all the way down into the root from the pulp cavity. We call that the root canal. The dentist, if you're having a root canal done, what the dentist is doing is they're drilling in, they're cleaning everything inside of it out, all that filling, cleaning it out, and fills it with a pin of sorts that gives your tooth a base for a new crown, essentially. Gums or gingiva are down in this section right here, in the middle section, right? The crown is the exposed part that you see. The neck is the part of the tooth that is in the gum and the gingiva right there. And the root is the part that is embedded down into the bone, right? So that's the bottom part. Cementum is calcified connective tissue, and cementum is what holds your tooth in place, essentially. We'll talk about that a little bit more with tooth and gum disease. So with teeth, as with anything else, there are diseases that go along with them. Cavities or dental caries are the most common. That's where the enamel and dentin have broken down. How? By sugar from food or drinks and bacteria forming a sticky plaque that turns acidic and eats through your enamel. Once it eats through your enamel, it's really easy to dissolve the calcium in your dentin, because your dentin is a lot softer, and it easily eats through that, and boom, you have a cavity. Once that cavity reaches the root, you have pain. So right before it reaches the root, you'll feel sensitivity to cold or hot food or liquid, and that's typically around the time you go to a dentist and they give you a filling so that it doesn't reach the root, so you don't have extensive amounts of pain and kind of stop that cavity in its tracks. Gingivitis, that happens when that plaque, that bacteria sugary plaque is there for so long that it calcifies and forms a tartar, a calculus. Calculus separates the teeth from the gums. So when a dentist or a dental hygienist gets that tool to scrape out your teeth, they are scraping that tartar or calculus so they can remove it and brush the plaque from your teeth. Flossing to prevent this is important, guys, because with gingivitis, when that pocket is deeper and catches more plaque, it causes more bacteria to get through. So what happens is that calculus, it separates the teeth from the gums. Know that. That will be on the quiz. It disrupts the calculus or tartar. It disrupts that seal between the gingiva and the teeth. Bacteria get in, infect the gums. That's where that bright redness, that bright red soreness happens. And these bacteria are anaerobic, so they don't need air to divide. They just are able to divide and replicate in these captive, oxygen-free environments. Now, this is reversible if you go to the dentist every 6 months and get that tartar removed. But if you are not going to the dentist, you're not flossing, more and more tartar is being built up and it stays too long, you can have a serious case of irreversible gingivitis. So take care of your teeth, go to the dentist, brush your teeth, floss your teeth. Really, really, really important. We're going to talk about how gum disease is also connected to heart disease right now, actually. So periodontitis, this is the worst one, right? So this is the worst gum disease that you can have. This is when your teeth start falling out. The periodontal ligament is the connective tissue that surrounds and supports the teeth. And this is the ligament that actually attaches to the bone socket. So with periodontitis, the periodontal ligament gets destroyed. Remember, itis is infection. So it's the infection of that ligament, and it actually gets destroyed. So your immune cells actually attack it, destroy the ligament, and then activate osteoclasts. So you remember osteoblasts build up bone? What do you think osteoclasts do? If blasts build up, clasts break down. So osteoclasts are breaking down the bone, getting rid of it completely, right? And this is what makes your teeth loose and cause them to completely fall out of your skull. The blood vessels in the mouth, like I just said, are very closely related to heart problems. So when there's bacteria in the mouth, it can actually cause heart trouble. It can cause more and more issues with atherosclerosis, and it can cause more issues with clot formation in coronary and cerebral arteries. So make sure you're going to the dentist regularly. Periodontitis is not one of those that you want to mess with. All right, so moving out of mouth teeth, going down to the esophagus into the stomach. Stomach time. So the esophagus comes into the stomach, and then conversely, right there at the bottom, the duodenum is the first section of the small intestine that goes out of your stomach. So the esophagus and the duodenum are not actually part of the stomach. They just, one leads in, one goes out, right? And then you have the stomach itself. So you've got this tight curve on the inside. We call it the lesser curvature. And you've got the greater curvature on the outside, or the bigger curve. So pretty easy to remember: lesser, smaller curve, greater, bigger curve on the outside. You've got the cardia of the stomach, so that muscle, cardia. You got the fundus right here at the top. That's a big curve up top. Write this down. The fundus, you could say, is the most superior domed region of the stomach. May or may not show up on your quiz. Write it down. Remember that. What this picture doesn't show you, so I went ahead and drew it in, is right below the esophagus is an esophageal sphincter. Kind of drawn that in. It keeps things from backing up into the esophagus out of the stomach. So think about why you don't want things coming up and out. Think acid reflux type stuff. This esophageal sphincter kind of helps alleviate some of that. Let's see. And at the other end, speaking of sphincters, at the other end, right before the duodenum, you have the pyloric sphincter. So the pyloric sphincter is the last part of the stomach for our intents and purposes before you reach the duodenum. And the pyloric sphincter keeps everything from going into the duodenum before it can be digested. So the pyloric sphincter actually closes while you're digesting. And once food is digested, that sphincter will send a few millimeters of content into your duodenum. So, fun fact, actually. So, you see the positioning of the stomach right here. It's upright, upright. If you ever have drank a soda and you've had a burp that you felt has been stuck that you couldn't get out, a nice trick is if you lay on your left side, so this is patient left, lay on your left side, so tilt this image down. What happens when you can't release a burp is that you have a gas bubble that gets trapped up here in the fundus, right? So if you lay on your left side and you tilt your stomach down, you've essentially moved your esophagus up to the top, and that air bubble will just bloop up through the esophagus and out of you. And now you have relieved yourself of that gas that accumulated in your fundus, all by laying down on your left side, causing your stomach to naturally tilt over to put your esophagus up at the top, move that air bubble, because the air bubble is going to stay exactly where it is. It's just the stomach that you're moving, and now the esophagus is lined up with that air bubble, and that air bubble can move up and out. This is also a good trick with babies. If you have a baby and that baby's tough to burp, try laying them down on their left side to try and release some of that trapped gas inside the fundus of the stomach. Let's see, what else? Oh, and then rugae. So inside the stomach, you can see all these wrinkly little bumps. They're called rugae. So what the stomach is doing, you can kind of tell from the shape of those bumps. It's actually rolling and kneading that food along. So K-N-E-A-D, think dough, kneading the food along with digestive secretions to get it all mixed up. So that bolus in your mouth that we just talked about from all the saliva, it's mixing with stomach acid here, getting kneaded through the stomach like dough while it's getting, stomach acids, gastrins, etc. are working on it, digesting it. And the rugae helps move all of that from the body of the stomach down to the pyloric region. So remember that. Towards the pyloric region, pyloric sphincter, pylorus, any of those, you will see that come up on the test. Helps it move from the body down the pyloric region. And that's the last part of the stomach. So here is a cadaver. So everything is packed in just like this. And if you are dissecting a cadaver, this is pretty much what it's going to look like. So the liver is ginormous right up here at the top. You can see the spleen right here on the patient's left side. What you can't actually see in this picture is the stomach. So the arrow is pointing at the stomach and it's supposed to be located right here. It's actually being covered up by this lobe of the liver. Liver has 4 lobes. This is one of them, and it's covering the stomach up. And then you have the intestines, large on the outside, small on the inside. Let's look at this next picture. So here's an artistic view of the previous slide, much cleaner. Omentum, which I haven't talked about. Omentum is just connective tissue. Here you can't see any omentum, not momentum. It's momentum without the first M. You can't see any here. It's cleaned up for, visual purposes. So you can easily see the liver, the gallbladder, the stomach, and the stomach here is exposed because somebody's holding this lobe of the liver up, and then this gallbladder is exposed because another one is holding this lobe of the liver out. See the duodenum right there leading out of the stomach. The duodenum actually tucks down into the transverse colon. So remember, transverse is across, and it begins the process of curling all the small intestines around. And remember, you got the ascending colon, transverse colon, descending colon, sigmoid colon at the bottom, and then the appendix. Remember, the appendix is right at that junction between the small intestine and large intestine. You can kind of see the bladder down here at the bottom here. But be able to label all of these things, all of these digestive organs. All right, so gastric glands. We have glands that create secretions that help digest food. Mucous neck cells secrete thin, acidic mucus, and that helps protect the stomach, actually. The other three that we're going to talk about in a little bit more detail are parietal cells, chief cells, and enteroendocrine cells. So, parietal cell secretion. HCl is hydrochloric acid. Hydrochloric acid is very, very, very extremely acidic on the pH scale. It is at a 1.5 to 3.5. So, what hydrochloric acid in our stomach does is it denatures protein in food. So, if you've ever eaten ceviche, ceviche is protein that's cooked in citrus juices. Essentially, that is what hydrochloric acid does to protein in our stomachs on a more powerful scale. It also activates pepsin, and it also kills a lot of bacteria. Pepsin is just a digestive enzyme. We'll talk about it just briefly. Parietal cells also give you what's called intrinsic factor, which is required for you to absorb vitamin B12. So once you get to the small intestine without vitamin B12, you can end up with a condition called pernicious anemia, which is simply a type of anemia caused specifically by a vitamin B12 deficiency. So remember I said I'll briefly talk about pepsin. So I just said that hydrochloric acid activates pepsin. Well, chief cells activate pepsinogen. And then pepsinogen turns to pepsin when encountering hydrochloric acid. So pepsin can also trigger itself. So this is a positive feedback loop. You don't find a whole lot of these naturally in the human body, but this is one of those things. So the more pepsin you have, the more pepsin you make. The more pepsin you have, the more pepsin you make, etc., 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 etc. And then lastly, enteroendocrine cells. We'll talk about these more in the nutrition chapter detail-wise. For our purposes, we're just going to touch on it and say that they secrete serotonin, histamine, as well as somatostatin and gastrin. But we won't delve into that too much, not until nutrition lecture. So, as with everything, there are issues that can occur. Homeostatic imbalances, if you will. Something that can happen is gastritis. So anytime you see itis, remember that's inflammation. Gastritis is inflammation of the mucus lining of digestive organs. So remember, gastro is anything that refers to the stomach. Itis, inflammations, or gastritis, stomach inflammation. When the actual stomach lining is breached and acid can get through, it's going to irritate the inside structure of the stomach. So that's what actually causes gastritis. This can be very, very painful and very, very uncomfortable. What can also happen are peptic or gastric ulcers. Ulcers, most of us have heard of. I hope most of us haven't had them. But that's when the wall of the inside of the stomach is breaking down. So there are literal holes in the lining of your stomach. So this is usually caused by a particular bacteria called Helicobacter pylori or H. pylori. So know that, you're going to have to know that. Write it down. For a long time, this was unknown to doctor scientists. Once discovered, it was found that a simple antibiotic can actually take care of most ulcers today, which is very fortunate. People back in the day really had to suffer before modern medicine. This is what it looks like, a gastric ulcer. On the left side, picture A, that is a lesion inside the lining of the stomach. So you can see how it's a literal hole. The grooves are normal. The ridges are normal. That's what we want to see. What isn't normal is that circular hole in the center. Picture B is a good representation of bacteria. They don't actually look this beautiful and green. Maybe they do. They're not going to look this beautiful and perfect though. But that's a picture of bacteria digesting the mucus layer of the stomach, creating those holes in it. So ulcers hurt, as you can imagine. That bacteria is literally eating a hole into your stomach. Gastric contractile activity. So what does that sound like? So remember I said that the stomach rolls and kneads all of the contents inside of it. Kneads as in Kneads, like you would knead dough. While this is most rigorous near the pylorus, the end of the stomach, closest to the intestines. Chyme, so Chyme is pronounced chyme. That's the combination of food and digestive acids and juices. Chyme is either delivered in 3 millimeter spurts into the duodenum, as I previously mentioned, or it can be forced backwards into the stomach and up the esophagus and out of your mouth as vomit, which would be very unfortunate. We don't want that, but that's what kind of happens. Gastric contractile activity at its finest. So the stomach empties out at a couple millimeters at a time, and that's so the other digestive juices that it encounters in the small intestine have a chance to get all of this chyme, this food mixture that you've created, and so they have this time to digest everything that hasn't gotten digested yet. So we have something called carb-rich chyme, carbohydrate-rich chyme, that moves through the duodenum, and it moves relatively quickly through the duodenum. So carbohydrates move relatively quickly through the duodenum. Know that. And then we also have fatty chyme. So your body is able to separate the fatty chyme from the food. It separates out the carbohydrates, the fatty, right? It's breaking it down. Enzymes are breaking food down. You want this to happen. And your fatty chyme actually stays in the duodenum up to 6 hours. And that's because fatty chyme actually requires bile from your gallbladder and your pancreatic juices to help break it down. So it's got to move more slowly through the small intestine so that it actually has time to be digested, unlike carbs that just zoom right through. If this fatty chyme does not have that time to get digested and goes straight to the colon, guess what happens? Diarrhea. Why? Because the food that's not been broken down feeds the bacteria that's in your intestines, large intestines. And so now your bacteria is eating that food and processing it as diarrhea. So you want all this to kind of function well. Otherwise, you're going to notice through the rest of this lecture that diarrhea will happen. Okay, so let's get into these accessory organs that we have been mentioning. So the liver here is huge. It's ginormous. Liver's right here. I don't think that I labeled it, but this is the liver. So know that that's the liver. You'll be required to identify it. The gallbladder is the little green pear right here. Pancreas right here. So the gallbladder has a cystic duct that comes off of it. The liver has a hepatic duct. So remember hepatic, you see hepatic, you know you're talking about the liver. Liver, so where were we? Gallbladder has a cystic duct. Liver has this common hepatic duct or just hepatic duct. When they come together, they form what we call a bile duct right here. So hepatic and cystic form a bile duct and joins into the duodenum. So liquid from the gallbladder goes to the cystic duct. Liquid from the liver goes to the hepatic duct. They come together, they form a bile duct. Now the bile duct combines with the pancreatic duct. It's right here. Pancreas, it has its own duct, the pancreatic duct. And it attaches, like I said, to all three of them. Well, 1 and 2 attach to this one, and then the third one attaches to the bile duct. Join at the duodenum. And where was I? I have lost what I was talking about. So bile duct combines with the pancreatic duct at the major duodenal papilla. So papilla is just this. Remember we were talking about papilla on the tongue? Essentially same thing. That's where they have joined and they are dumping into the duodenum. So right there at this major duodenal papilla, we have liquids from the gallbladder, the liver, and the pancreas all squirting out. Lovely. Now remember where your stomach attaches. Your stomach attaches right here at the top of the duodenum. So it kind of sits right here, if you can imagine it. Boom, stomach. So whatever's coming out of the stomach and into the duodenum quickly gets blasted by liquids from those 3 ducts, from those 3 organs. The gallbladder, the liver, and the pancreas. So the cystic duct, the common hepatic duct that join together to form the bile duct, and the pancreatic duct are all blasting whatever's coming through with some digestive juices. So the liver a little bit more. It is the largest gland in the body, and it's made of 4 lobes. So we've got the right lobe, the left lobe, the caudate lobe, and the quadrate lobe. Quadrate just means 4. So right, left, caudate, quadrate. Caudate, quadrate. It's a little bit of a tongue. What is it? What is it called? Tongue twister? Sally sells seashells by the seashore. 4 lobes, right, left, caudate, quadrate. Hepatic, like I said, is anything liver. So we've got the hepatic artery in the vein. We've got our bile ducts, so our common hepatic from the liver connects to the cystic duct from the gallbladder and joins to make the bile duct. These are just words associated to what I said while we were talking in the diagram. Microscopically, the liver actually forms these little hexagon shapes. So we've got these tightly packed little hexagon units, kind of like a beehive. What they do is they actually filter and process nutrient-rich blood. They take out the nutrients, they filter out the wastes, and then that would continue through the bloodstream to be filtered out by the kidneys. So there's a huge network of blood vessels here, and these longitudinal central veins in each of these hexagonal shaped liver lobules, if you will, they are their own little network of blood vessels, and the central veins collect from all of these little blood vessels. And like I said, they collect all the nutrients, filter out wastes, and direct basically where everything goes. But what does the liver actually do? So the liver processes nutrients, it stores fat-soluble vitamins. We're going to come back to that heavily in nutrition chapter, but remember this because it's going to be a big deal in a minute. So you will have to remember which vitamins are associated with fat soluble versus water soluble. Anyway, the liver performs detoxification, so it removes toxins. The liver produces the bile that's stored in the gallbladder. So we used to call the bile gall. So if you guys think that gall and bile is different, it's not. We just call it bile nowadays. You can call it either one. You're going to see it written as bile everywhere, though, so we're just going to stick to bile. And it produces about 900 milliliters of bile per day, actually. So the pancreas is one of those organs that has both endocrine and exocrine function, and we have talked about this several times throughout the semester. We're just going to touch on it a little bit here. So its endocrine function is in the secretion of insulin and glucagon as a response to the amount of sugar in the bloodstream, right? Exocrine function, though, is what we're going to focus on here. So exocrine function, it secretes pancreatic juice, which helps to break down your food at the duodenum via the pancreatic duct. Come right back to it. So pancreatic juice, yummy, yummy. What's in it? So first of all, it's basic, right? It's alkaline. It's basic. I like to say basic. A lot of people like to say alkaline. But it has a high pH. pH is 8. So it neutralizes that acidy chyme that we were just talking about. So remember, chyme deals with hydrochloric acid. Hydrochloric acid is super, super, super acidic. It needs something to balance it back out, right? Because if hydrochloric acid goes through your gut, it'll eat the lining of your gut. So think when you have massive diarrhea. Yes, we are going to talk about diarrhea a lot. So think about when you have massive diarrhea and it's round 3 or 4 and you are burning. We have all been there. If you haven't, count your lucky stars because it's coming. But anyways, the hydrochloric acid is actually what causes that bad burning feel. It's moving through your system way too fast and it doesn't actually have time to be neutralized by pancreatic juice with that pH of 8 that is functioning to neutralize that. So that's what that does. There are also enzymes in pancreatic juices. Amylase breaks down starch. Amylase is also in the mouth. And then lipase breaks down lipids, which are fats. Now these do require bile to activate the enzymes. So fun fact. So like we just said, bile is produced by the livers and goes to the gallbladder. Gallstones can actually prevent bile from moving through that duct. It can close off that duct and it can cause issues with enzyme production. So, just a fun fact. Something cool to know. Regulation of bile secretion. So when there's hydrochloric acid and fatty chyme in the duodenum, that is actually what stimulates the gallbladder to secrete bile. So that's that regulation piece. Alrighty, moving on down towards the rectum and the anus. We talked about hemorrhoids in a previous chapter. So hemorrhoidal veins are the veins down there that can be swollen if they get irritated. They can be inside the body or outside the body. And then we have the external, internal anal sphincters. They open and close for gases, liquids, solids. You very consciously control that external anal sphincter. If you are potty trained, you are controlling that external anal sphincter. You have very conscious control of that. And then the anus. So inside the intestine, we have to have bacteria. We're talking good bacteria. So if you don't have this good bacteria, this good bacterial flora, and you've got an overload of bad bacteria, that can create issues like lack of nutrient absorption. And what's the favorite thing that we're talking about today? Diarrhea. Tons of gas can also happen. So the good bacteria, they enter from the small intestine or the anus, and they ferment indigestible carbs. So what are indigestible carbohydrates. We're going to talk about this in the nutrition lecture, but we have to talk about this here too. So think fiber, insoluble fiber. This causes gas. Any high fiber veg, so cabbage, broccoli, cauliflower, that also has some sulfur content, and you are gassing it up smelly style, right? Anyways, let's get back on track. Bacteria digest these indigestible carbs and they make you release pretty irritating acids and gases, but they also synthesize vitamin K and B complex vitamins. Motility in the large intestine, the gastrocolic reflex. So gastro, stomach, colic, colon. This is when you eat something and get your stomach moving. So this gets activated about 3 to 4 times a day through slow, powerful peristaltic waves in the colon. So think about it as you usually eat about 3 to 4 times a day, and that's what moves that food mass and causes that bowel movement out into the toilet. So the process of eating helps cause this peristaltic wave and causes you to feel the need to poop after about, 30-ish minutes after eating in the mornings, maybe, just as an example. But really what's moving out of your body is whatever you ate 2 to 3 meals ago. So 3 to 4 of these a day, normal to poop about once per day. So your gut's holding about 2 to 3 meals a day. So as you eat one goes out, but it's 2 or 3 meals are kind of staying consistently inside of you, as they should. Defecation, aka pooping. So mass movement, it forces feces into the rectum. When you get to the end of the rectum, there's a stretch reflex that triggers your spine to tell your brain, to tell your muscles that it's time to find a toilet stat. And like I said before, conscious control allows you to control the external anal sphincter so you don't defecate on yourself. Vitamin absorption, if asked, which are fat soluble versus water soluble, be able to differentiate. So these next 3 slides are really prepping you for the nutrition chapter, but we're going to touch on them just quickly in terms of how they affect digestion. So the whole point of this is you got to absorb your vitamins. In the small intestine, you have fat soluble vitamin A, D, E, and K. Remember that. Fat soluble are A, D, E, and K. You have water soluble C and B vitamins also in your small intestine, but the fat soluble are A, D, E, K. Water soluble are B and C. And then you have vitamin B12 with intrinsic factor. Large intestine, vitamin K and vitamin B are absorbed from bacterial metabolism. Remember, in the small intestine, fat soluble, A, D, E, K, water soluble, B and C. Water absorption. So 95% of water that gets in the gut's reabsorbed in the small intestine. Malabsorption, and what do you get? Diarrhea. Malabsorption. So anything that intervenes with delivery of bile or pancreatic juice, damage in intestinal mucosa caused by bacterial infection. So these are any of the issues, anything that interferes with it. Bacterial infections are the most common that can cause malabsorption of nutrients. Something else that can cause malabsorption of nutrients is actually allergies. So celiac disease is a legitimate gluten allergy, gluten sensitivity. So celiac disease is gluten sensitive enteropathy. So gluten damages the lining of your intestines due to allergies. So some people with severe cases can't even use shampoo with gluten. But if they eat it, if they eat anything with gluten in it, somebody with a severe allergy, they're going to get very, very bad gas, very, very bad cramping, a lot of diarrhea, sometimes for days. Now, I will say mucus lining is resilient and it will repair itself quickly. Not as quickly as like the mucus lining in your mouth does, but it will repair itself. So if you do have crazy bouts of diarrhea or whatever, know that eventually it'll repair itself. But if you have this gluten sensitivity, you're going to have to eliminate gluten from your diet. It's hard but manageable to reduce issues because you don't want rectal bleeding from a destroyed mucosal lining, right? But anyway, that's it. That's all I got for the digestive lecture. Let me know if you have any questions. Goodbye.